So good morning, everybody. Thank you for logging in to this morning's chilly webinar and asthma grand rounds. Today, we are welcoming Dr. Krishnan, who's an associate professor in emergency medicine at Beth Israel Deaconess and working out of the Center for Vascular Biology Research, I believe. Dr. Krishnan is a mechanical engineer by training and has used really that lens to examine biophysical properties in pulmonary endothelial cells, epithelial cells, and smooth muscle cells. He's also used that training to develop new models of airway smooth muscle contraction for drug compound screening and to develop human precision cut lung slice platforms for drug discovery in both airway and fibrotic disease. So Dr. Krishnan is the author of over 80 publications on these topics and a recognized leader in mechanobiology and lung physiology. So it's really a pleasure to welcome him here to speak with us today on airway smooth muscle pathobiology in asthma exacerbations. Thank you so much for joining us.
Thank you, Nora, and pleasure to be here. Thank you for the invitation. Let's see. So let me begin by disclosing my commercial interests. I have co-founded several companies. I consult for other companies, but I want to reassure the audience that none of this is going to impact the science that I'm about to present to you today. I like to provide a context, and as a mechanical engineer, mechanobiology, I like to begin my talks with an exercise. So when I count to 3, I want all of us here at this call to join me in taking a single deep breath. Okay, so when I count to 3, 1, 2, 3, please. It's good, right? So it turns out you do that involuntarily, sometimes on purpose, you sigh. You do that 6 minutes or so, you do that every 6 minutes. And every time you do that, your airways that can sometimes constrict will immediately dilate. In fact, of all natural strategies that your body uses to keep your airways bronchodilated, that deep breath you took is amongst the most effective strategies. However, if you have asthma, you treat patients with asthma, or you know someone with asthma, you know that this effect fails. A deep breath does not dilate their airways. In fact, they have difficulty breathing and accommodating that deep breath. Now, this is by no means my discovery. This has been known for hundreds of years and pursued by leaders in lung physiology, smooth muscle mechanics, asthma pathobiology, and they've discovered important mechanisms to explain this difference. They found roles for airway smooth muscle mass, airway smooth muscle tone, contraction velocity, parenchymal tethering, inflammation. But a common mechanism to explain this difference has remained elusive. To elucidate this mechanism, I turned to the human precision cut lung slice. These slices, they're approximately 200 to 500 microns thick. Well, we prepare them at our defined thicknesses. The 45 odd cells in the lung are all present in these lung slices. These are living. Those cells are interacting realistically. Importantly, you can look at the airways directly. So that's one of the airways. You see the bronchial epithelium, you see smooth muscle, and these you can place in a dish and you can do experiments with them. Let's do such an experiment. And I want you to keep your eyes on the airway. We first add methacholine to induce constriction and then superimpose breathing. Likely noticed with methacholine, the airway is constricted, but when I was breathing them, they got bigger, 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 bigger. In fact, if I waited for even longer, these would return back to where we started, pre-methacholine value. Don't take my word for it. I've done this experiment, many lungs, many slices, many airways, and I'm showing you here average data. On this axis on the y-axis is the reversal of constriction, and on the x-axis is the amount of stretch, the magnitude of stretch. Difference is not important for now, for this talk. But the message here is the more the stretch you impose, the more reversal of bronchoconstriction you get. So in circumstances like this, you can completely reverse that pre-existing bronchoconstriction. Now, those were done in non-asthmatic lung slices. Let's repeat that experiment, but this time in an asthmatic lung slice. The choline, breathing. that airway stays constricted. Now, you're probably wondering what's going on here. To get there, let's now turn our attention to the airway smooth muscle that surrounds these airways, especially its contraction. And I'm showing you here another representative lung slice, muscle, and here is a map of contraction that muscle exerts in response to methacholine. So this is that contraction map. Colors represent magnitudes, and the arrows represent the direction of contraction. What we will do now is take that lung slice and superimpose a big stretch, unstretch. So this is like, so it's resembling a deep breath. And I'm going to play a movie. The first couple of frames are in this region A, that is before I impose the stretch. And the rest of the frames are after stretch. Keep your eye on these maps. Before stretch, before, immediately after, and with time. We can be more quantitative about this. From every such map, we can get a single number for contraction. And I'm showing you here how that number varied during this experiment. This region is in this A. Well, nothing really happens to that contraction. But as soon as I imposed that stretch, you can see it dramatically reduces. And over time, things have come back to where we started. To get to mechanism, we have to go down another length scale, this time to the cultured human airway smooth muscles. This is one of those cells that has been cultured in a dish. Now, one of the things about the human airway smooth muscle cell, or really any of these adherent cell types, is when you place them, culture them in a dish, they're not just simply blobs that float about, but they're adherent. And not only are they adherent, but they're also contractile. We have approaches, which I'll get to in a little while, where we can directly map those contractile forces. For now, for that cell, here is a corresponding map of contractile force. The colors represent magnitudes. The hot colors are high contractions. And arrows here, they're all, well, you may not be able to see it, but there are arrows here, they're all pointed inwards. So this cell is adherent and contracting that substrate inwards. So let's take that cell and repeat my favorite experiment, that single deep breath. Keep your eyes on that contour. Again, first couple of frames are here before stretch, and the rest of the frames are after stretch. Before, immediately after, and with time. Here is the quantitative representation for this. Before stretch, forces hardly change. Immediately after stretch, you can see that they're dramatically reduced, and with time, they've recovered. Done this experiment, many cells, many lungs, and I'm going to show you next average values. But in order to average it, what I did is on a cell-by-cell basis, I took forces after stretch and normalized it to its own pre-stretched value. So next, I'm going to show you normalized contraction as a function of time after stretch. And this is in the case of no stretch, small, medium, big stretches. No stretch, well, nothing really happens. The cells are adherent and sitting there. But even a small amount of stretch can dramatically reduce that force and induce these force dynamics. 10% stretch reduces it by about 75%, and then these forces eventually recover and return to baseline. Around the time that I was doing these experiments, my colleague at the time, Dr. Xavier Tripat, who's now a professor of bioengineering at the University of Barcelona, was doing similar experiments with airway smooth muscle cells. But rather than measuring contraction, he was measuring cytoskeletal stiffness. And we were imposing similar experimental protocols. So this is contractile changes, this is stiffness changes. That similarity is striking. In fact, if I plotted normalized contraction, not as a function of time, but I plotted normalized contraction as a function of normalized stiffness, you get a nice linear relationship. That is to say that these changes of contraction are intricately linked to changes in stiffness. At the molecular scale, we have learned that this linkage is mediated by F-actin dynamics. Went back to our favorite protocol. This time, at a stretched cultured cells, stretch protocol, fixed and stained cells for F actin immediately after stretch. So in that region, stained for F actin. Here is a dish of cells where I'm showing you F actin staining in cells outside the stretched region compared to cells inside the stretched region. This is immediately after stretch. It's day and night. In fact, when done over many cells, many dishes and so on, what we learned is immediately after stretch, that F actin substantially reduces in content. Look at this. This is unstretched compared to immediately after stretch. We then took another dish, another group of dishes of cells, and this time we fixed them here. And when we measure F actin, all of that F actin reappears, recovers. We also validated these experiments with Westerns for G and F actin. I'm showing you here the F actin fraction. Compared to no stretch, you can see that this F actin almost completely disappears. For our setup, we couldn't even measure it. But 2.5, 5 minutes after stretch, it all returns back. Now, we went deeper. We focused first on the actin severing protein called cophilin. Favorite protocol, and we measured contractile force changes. And we compared control cells with cophilin knockdown cells. So first control cells, for that protocol, expected outcome. You see this dramatic decrease of force followed by recovery. But in cophilin knockdown cells, we observed that the force reduction was dramatically smaller, though in time, these forces recovered back to the same value, which is to say that this acute force reduction after stretch is mediated by cophilin. We next focused on an actin-restoring protein called zixin. Now we observed that compared to wild-type cells, shown in blue, zixin knockout cells relaxed to a similar extent, but the subsequent recovery was significantly reduced. That is to say that the force enhancement after stretch is mediated by zixin. Now, full disclosure, this is, it's still quite, I would say, current. This is a subset of proteins that encompass the focal adhesion in airway smooth muscle. I've so far told you about cophilin, zixin. As you can see here, there are so many others. And how all of these guys interact and regulate this response remain to be studied. And potentially these could be useful as targets to enhance fluidization in the airway smooth muscle. But beyond the focal adhesion, over the last decade, longer, there has now been quite some interest in looking at inter and intracellular proteins that regulate F actin dynamics in the airway smooth muscle. These include transgelin, c-Abl, ROCK, Rho, integrins, N-cadherins. I'll come back to all of these in a little bit, but I want to set the stage here to tell you that targeting the F actin cytoskeleton is a real thing, to which I'll come back to in a little bit. But for the moment, it suffices for me to tell you that from molecular measurements, cellular measurements, lung slice measurements, and real experiences, we've now come to learn that in response to stretch, the airway smooth muscle promptly fluidizes. And by fluidization, I'm referring to a physical phenomenon that is characterized by a prompt reduction of airway smooth muscle contractile forces, prompt cytoskeletal softening, enhancement of molecular rate processes in the cell, as well as prompt actin depolymerization. And it is this fluidization that enables your constricted airways to reopen. And we've been testing the hypothesis that in asthma, it is the failure of the airway smooth muscle cell to fluidize that is the proximate cause of bronchoconstriction. Now, this is an interesting hypothesis, mechanistically important, but if you are an asthmatic, know somebody with asthma or treating asthma, just knowing that stretch doesn't fluidize is not a complete answer. It's not at all sufficient. How do I fluidize then my airway smooth muscle? Well, fortunately, we have bronchodilators. Unfortunately, these don't reach everyone equally. We know that well. If you've kept up with the literature the past, I would say 10, 20 years, there's been a number of exciting new candidates that we can develop to becoming new bronchodilators. The major issue is that the assays that can take you from a chemical entity to a drug candidate have been poor. Let me explain. Let's look especially at the case of the airway smooth muscle and its contraction. A typical approach in drug discovery is you would You have a target. You likely have 10,000 compounds, chemical entities that can hit your target. You now have to prioritize. You have to pick 3, 4 that you want to develop further. How do you do that? So you have 10,000 candidates. You first start with something called high throughput screening. In the case of the airway smooth muscle contraction, these are the 3 standard assays. You measure intracellular calcium, cyclic AMP accumulation, or you can measure membrane potential. Using these measurements, many of these emerging candidates have been previously screened. The problem is, ultimately, the relationship between this measurement to muscle contractile force has been hard to discern. In fact, in many cases, they've been of the opposite sign. Calcium has gone down, but forces have actually enhanced, and the opposite. So it's been complicated to interpret. Now, you can directly measure airway smooth muscle contraction. Labs like mine, bioengineering labs, this is kind of what we do for a living. Here are some of our assays that have been in existence and are routinely used. Magnetic twisting cytometry. Beads are added to a culture of airway smooth muscle cells. They get adhered to the cells. You put them in a magnetic field and you apply a force. Based on how much they move, you measure stiffness, which is a surrogate for contraction. Another approach is muscle on a chip. Another approach is atomic force microscope. You can poke locally and you can get a sense of how much contraction you get. Problem is, these measurements are slow. I mean, here you're talking, small indentations, this is not throughput. They also come in slow throughput, single well dishes, 6 well dishes. So this is not drug discovery amenable. And they're complex to interpret. Here, the way that the muscle on a chip approach works is cells are cultured in a monolayer. Based on how much they contract, the membrane bends. Bending to contraction, trust me, as a bioengineer, I can tell you that relationship is not a simple one to ultimately to calculate to spit out a force value. So what we ideally needed was a direct measurement of muscle contractile force, ideally in a high throughput screening format. We developed an approach called contractile force screening. This approach is fast. It uses physiological stiffness substrates, i.e., it can recapitulate the stiffness of what that muscle cell would feel in its natural environment in our lungs. It can directly measure force. And for those in the audience who have or work with high throughput screening, this assay is also of high statistical quality. Suffices to say, by that measurement, we've confirmed that this can discern hits from noise. The core method that makes this possible is the method of traction force microscopy. Smooth muscle cells are cultured on soft substrates. And again, remember I told you this is in the kilopascal range. And for the non-engineers, kilopascal is like stiffness of shaving foam or toothpaste between your fingers. That's a few kilopascal. However, toothpaste, shaving foam, you squeeze, it just spreads. These don't just spread, these are elastic. So you squeeze, it deforms, but when you when you remove the applied force, it bounces back to where you started. So this is an elastic, so it recoils, it returns to where you started. So we have substrates that are soft, elastic, but these are also, and these are also transparent. So you can look through the substrates, you can image the cells. You can also image a layer of fluorescent beads that we spin coat in one single layer on the just underneath the cells, right on that substrate. So you can look through and look at these cells and look at these beads. And in the experiment, what you do is you're really looking at displacement of these beads, because these beads displace when the cells contract them. So you can measure bead displacements. We know that substrate stiffness. We can tune it. We build that substrate to a certain stiffness. And then from this and that, you can directly calculate a contraction force map. And from a map like this, you can get all kinds of measurements, average, median, mean, so on. For example, we would get a single number that represents an average contractile force. In a typical experiment, you do this measurement at baseline, and then you repeat that measurement after whatever treatment. And all one has to do then is force over treatment divided by force over baseline. That's it. Compute a force response ratio. And that single number tells you everything you need to know. Let me give you a few examples. This is a force map in smooth muscle cells in a monolayer of smooth muscle cells. And this is a map at baseline. This monolayer was treated with a vehicle. And here is a map after that treatment. Average force pre, average post. All you do is get a ratio, 1, no change, and that compound is doing nothing. Next, you have a contractant. So forces went from 26 to 46, ratio bigger than 1, contractant. Rho kinase inhibitor, forces went from this to that, ratio of less than 1, relaxant. So that's it. All you need to know is this force response ratio. And from there, you can immediately infer the function of your compound. Is it contractant? Is it relaxant? So here you are. So that's the outcome measurement we've employed. So now we have an assay, we have an outcome measurement. The first thing we did is validate it. And to do this, we picked the obvious choice, beta agonists, because these are well known to relax airway smooth muscle. We went further, we picked 4 beta agonists that are closely related. We tested them side by side in a 96-well plate at dose responses, and we also averaged data over multiple 96-well plates. And I'm going to show you next the average force response ratio. So this is the average force response ratio as a function of dose for formoterol, sal, isoproterenol, and salbutamol. In each graph I have on the top is a 15-minute after treatment curve, bottom is 30-minute after treatment curve. And each point there is a mean and standard error across 8 separate wells. You can see that in many cases, there is no error bars plotted. It's not because these were not plotted, it's because the errors are very small. Now, what you can do is when you get data like this from each of these curves, you can compute what's called an IC50 value. That's the potency. That's the dose at which you get 50% of the response. When we did that, here is the data we obtained. And from this, you can rank order your compounds. And this was actually very pleasing to see because going into the study, based on previous experiments done in mice, human studies, mechanistic studies, that is exactly what you would have expected in terms of order of potency. So then we had a valid assay. Let's now do the fun part. Let's do some screening. We focused on a library of compounds that are all FDA approved and in clinical use. Not just for asthma, but cancer, bladder dysfunction, what have you. Our rationale was perhaps we might discover 1 or more compounds in this library that we can repurpose in the settings of bronchodilation and asthma. So we made mixtures of 4 from this library. We tested 8 mixtures per drug plate, 4 plates a day, 3 days a week, and we were able to accomplish that screening in approximately 3 weeks. Here is now raw data results. This is force response ratio for each of those individual mixtures that we tested. We picked a cutoff and we focused on those mixtures that were below our cutoff because these are the ones of interest because below the cutoff force response ratio less than 1 are potential bronchodilators, potential compounds to relax the muscle. But remember, each of these is a mixture of 4, so we deconvoluted, repeat tested things individually, and after all of this, we detected several hits. Now, this library also has beta agonists, so many of these hits were not beta agonists, but we also detected statins. We focused in particular on the lipophilic statin called pitavastatin. The brand name in the clinic is called Livalo. We focused on this statin, and we first examined cytotoxicity. We took the statin, tested it, we used a standard viability assay, tested pitavastatin at many different doses across many different incubation times, and we compared data with either no treatment or with vehicle treatment. No differences. That is to say, there really is no observable cytotoxicity. We then measured dose responsiveness. In each group here, cells were first treated with histamine. You can see nice contraction. And then we had increasing doses of pitavastatin. And with the increasing pitavastatin dose, we got increasing relaxation of the airway smooth muscle. In fact, at these high doses, 50 and 100 micromolar, the forces reduced to baseline and even below baseline. So this was pretty exciting. And this is about, I would say, this was done about 5-6 years ago, and a lot has happened since. Enabled by this finding, together with Dr. Ami Zeki's group at UC Davis, we're working on various models and experiments to turn pitavastatin into a new bronchodilatory inhaled medication. Let me share with you some additional supportive data. We compared pitavastatin with isoproterenol, which is a beta agonist, beta 1 plus beta 2, a lab reagent. And we wanted to know, how does it perform with respect to either isoproterenol alone or pitavastatin plus isoproterenol? In this case, all cells were first pre-treated with histamine to induce contraction, and then either vehicle in black, beta agonist alone in red, beta agonist plus pitavastatin shown in light and dark blues. What we observed is, compared to beta agonist alone, the combination inhibited forces to a much larger extent. So look at this compared to these two curves. And not only was the magnitude bigger in terms of inhibition, but the forces also stay inhibited for much longer. So both the magnitude and duration of the beta agonist compound can be enhanced by addition of pitavastatin. And we also observe these similar data in mouse lung slices. So these slices were first pre-constricted with methacholine and then treated with either vehicle, pita alone, formoterol alone, or pita plus formoterol. We saw benefit of a combination treatment. And from these data, we learned that pitavastatin can enhance both the magnitude and the duration of beta agonist's ASM relaxation effect. We then asked, well, this is interesting. What is the mechanism by which pitavastatin is relaxing the muscle? The obvious place to start, of course, is mevalonate, because as you're likely well aware, pitavastatin is used in the clinic to lower cholesterol by inhibiting mevalonate. We therefore said, let's look at a condition of pitavastatin alone, which I'm showing you here in red, and let's compare it to pitavastatin plus mevalonate, which I'm showing you here in pink. And the expectation was, if pitavastatin's effect is mevalonate dependent, if pitavastatin is working by inhibiting mevalonate, adding mevalonate should cancel pitavastatin's relaxation effect. When we looked at the data, if anything, adding mevalonate enhanced pitavastatin's effect. It didn't reduce it. We also looked at similar data. We performed similar experiments in mouse lung slices, and we noticed that regardless, you add pitavastatin or pitavastatin plus mevalonate, you get similar extents of acute bronchodilation. This is to say that this acute forced relaxation by pitavastatin is not mediated by mevalonate inhibition. We then turned to calcium. We compared pitavastatin alone, shown here in black, with pitavastatin plus these known calcium chelators, either EGTA or EGTA plus caffeine plus nifedipine. And here are direct measurements of intracellular calcium dynamics. As expected, you use these chelators, you get differential calcium dynamics. But similar conditions, we measured force changes. Nothing really obvious. With or without these chelators, the force dynamics looks pretty much the same, from which we concluded that this acute relaxation appears not mediated by intracellular calcium signaling. We then looked at the F-actin cytoskeleton itself. We compared untreated cells with pitavastatin-treated cells. And I'm showing you here low magnification image, and these are high magnification image, untreated versus pitavastatin-treated. Looking at this by eye, or you can be more quantitative, the message here is pitavastatin disrupts the F-actin cytoskeleton. We were more quantitative about this. Many dishes of cells, many conditions. We compared the F to G actin ratio. We compared between vehicle and pita treatment. And we observed that pitavastatin significantly inhibited this ratio. So from these data, we concluded that this acute forced relaxation effect is mediated by F-actin depolymerization. We went deeper. We focused again on mechanisms by which actins can depolymerize, and our lead candidate was kefilin. We looked at how pitavastatin can affect kefilin's biology and function. We observed that pitavastatin treatment dephosphorylates kefilin. Now, to those in the audience familiar with kefilin's biology, it is when kefilin gets dephosphorylated that it becomes active. It is the dephosphorylated kefilin that can bind to actin and depolymerize actin. So from all of this, our working hypothesis is that pitavastatin dephosphorylates kefilin. By dephosphorylating it, kefilin can now act on the actin and thereby depolymerize the actin. And collectively, these changes can reduce airway smooth muscle contraction. I want to conclude this part. We've learned that pitavastatin is able to acutely depolymerize the F actin cytoskeleton, and in this manner, reduce airway smooth muscle contraction. And our current model is that pitavastatin, when delivered inhaled, may thus be a robust strategy to fluidize the airway smooth muscle and thereby reduce airway hyperresponsiveness. I've shown you here part of the story that is focused on muscle contraction, but I want to emphasize that work in Amir Zeki's lab is extending these data to also look at additive benefits towards reducing airway inflammation or reducing airway remodeling. So far, we have seen pitavastatin can do all of these things simultaneously. So you've heard so far as to how our approach of high throughput force measurements led to the discovery of pitavastatin. I want to now spend a few minutes talking about another recently completed study. This was done together with Dr. Kirk Drury, who is formerly just retired as Chief of Vascular and Lung Inflammation at NIAID. Well, Kirk's group has put forth a compelling hypothesis for fungal asthma. The fungal allergen, the protease, can infiltrate the bronchial epithelium and directly attack the airway smooth muscle. By doing so, it promotes airway smooth muscle contraction and thereby induces airway hyperconstriction. I'm excited to say that we can recapitulate this effect with our high throughput force measurement approach. Y-axis here is contraction, and I want you to focus especially on these black bars. No protease with protease. We observe that protease treatment can directly enhance muscle contractile force. Cytoskeletal compounds, such as rho kinase inhibitor, can also inhibit that enhancement. Importantly, these data were collected in a 96 well-played format. Therefore, we can use our approach to screen for inhibitors of allergen-induced ASM contraction. So in this manner, we can develop a precision therapy for fungal asthma and exploit a mechanism and a causal cascade that has not really, to my knowledge, ever been targeted for the purposes of bronchodilation. We're also looking at several other bronchodilatory pathways. Some of these are receptor-mediated, some others are cytoskeletal-mediated. And we aren't just limited to bronchodilation. We can also use this approach to understand mechanisms of bronchoconstriction. For example, we are using this assay to look at how in the settings of RSV infection, what are the mechanisms or targets that can be studied that ultimately force the muscles to hypercontract. We can also look at genetic susceptibility. We have access to 30-ish donors of normal versus asthmatic. We can screen them for their genetic composition and look to see are some cells genetically predisposed to hypercontract, all else being the same. Something like a GWAS type analysis, but this time directly with a functional endpoint. In the time I have left though, I want to end by focusing on this additional bronchodilatory mechanism, N-cadherin antagonism. To those unfamiliar, N-cadherin is an intercellular protein that is largely restricted to the airway smooth muscle in the bronchial airways. It is not to be confused with E-cadherin. E-cadherin is it's a homolog present in the epithelial cells, but these can be individually targeted. So anyway, N-cadherin is largely prevalent in the airway smooth muscle, and our conventional picture of its function is as follows. N-cadherin binds to beta-catenin to aggregate actin filaments. And by doing so, its major function is to transmit contractile forces from one cell to its neighbor. So it's an intercellular protein that is able to transmit forces. This is the conventional view. From direct molecular measurements, we have learned about an additional important function. N-cadherin can also bind to delta-catenin, promote actin polymerization, and directly enhance ASM contraction. This is independent of any intercellular force transmission effects. It can directly promote actin polymerization and thereby enhance force in the cells. And what's interesting is this whole pathway is independent of canonical excitation contraction pathways, i.e. canonical actomyosin, calcium dependent. This is independent of all those changes. To examine its therapeutic implications, we focused on an N-cadherin antagonist that has already been validated as safe to use in humans, a compound called ADH1. It successfully passed phase 1 and got into phase 2 testing. Using ADH1 as our compound, we compared either vehicle-treated with ADH1-treated airway smooth muscle cells. First, we used our contractile force screening approach to directly measure forces, and we noticed that ADH1 treatment substantially reduces forces, both at baseline as well as in the additional presence of histamine. So it can substantially reduce muscle contraction. In mouse lung slices, we observed that pre-treatment with ADH1 can substantially reduce airway hyperconstriction. And this is dose dependent. So bigger dose, you can get bigger therapeutic benefit. And in human lung slices, so this is where you pre-treat with ADH1 and then you post-treat with methacholine. So this is a bronchoprotective effect. We also wanted to understand, can it be a bronchodilator, i.e. can it overcome pre-existing contraction? So to do this, we took human lung slices. We first treated slices with methacholine. So this is in red is donor 1, donor 2, donor. So 2 different donors. Methacholine gives you contraction. We then added formoterol. In this case, you can see this formoterol fails to function because we have a model here of beta agonist desensitization. And we did this on purpose. We picked a model where formoterol fails to function, but then when we added ADH1, it overcomes the defect. You get nice bronchodilation. So ADH1 can overcome the desensitization effect, settings of desensitization with beta agonists. We then turned to mice. We directly measured airway resistance in mouse lungs to increasing methacholine doses. Compared to PBS treated, shown here in green, mice that were sensitized and challenged with aspergillus, shown here in blue, had enhanced airway resistance to increasing methacholine dose. Acute ADH1 treatment. So all we did here is treated ADH1 for 24 hours prior to this measurement. So the mice have been sensitized, challenged for 2 weeks. Just a day prior to measurements of airway resistance, we pre-treated the mice, with ADH1, and you can see significant benefit. It reduces airway hyperresponsiveness. These were done in naive mice. We also confirmed this in a mouse model of conditioned N-cadherin knockdown. First, wild-type mice. Well, you can see the control mice, you get sensitized and challenged, you get nice airway hyperresponsiveness. But in the knockdown mice, this is completely reduced. What's interesting is, and with mouse experiments, at the end of the experiment, we can measure allergic inflammation, we can measure airway remodeling. None of that was really affected by ADH1 treatment. But from corresponding mouse lung slice measurements, it appears to directly reduce muscle contractile force. We then looked for human relevance. We validated using human. We compared airway smooth muscle cells from fatal asthmatic donor lungs with control, and we observed there was more N-cadherin in fatal asthmatic airway smooth muscle cells. We also looked at where that N-cadherin is located. So from these lung sections, asthmatic lung sections, we observed that the N-cadherin is indeed localized to the airway smooth muscle bundles in the airways. Okay, well, that's interesting. And we've now started to ask the question, why? Why is there more N-cadherin in these asthmatic muscle? We took non-asthmatic cells and we treated them with many different Th2 cytokines and asthma cytokines more generally. And we observed that it is uniquely in the settings of TGF-beta that we get this enhanced N-cadherin expression. So these data implicate a TGF-beta dependent mechanism operative in severe asthmatic lungs that can enhance this N-cardiolin expression and thereby promote muscle contraction and so on and so forth. These mechanisms are of active interest and are currently being pursued in my lab. But what we've learned from here is in severe asthma, this N-cadherin appears to be essential for airway smooth muscle contraction. It is able to overcome its antagonism, I should clarify, is able to overcome beta agonist's functional tolerance. And this pathway can be targeted simultaneously with airway inflammation because it appears to not change anything in terms of the inflammatory pathways, but for TGF-beta that we've just discovered. Thus, this approach may be a robust strategy to inhibit the F-actin cytoskeleton, fluidize the airway smooth muscle, and ultimately to reduce airway hyperresponsiveness. With that, I thought I would end a little early so there is time for questions, but I want to especially acknowledge members of my lab, trainees in my lab, other lab members, are fantastic, and really, I'm very fortunate to have worked and collaborated and being mentored by a number of people here in this list, funding sources, and I thank you for your attention.
Thank you so much for what an exceptional talk. Very thought-provoking. Really appreciate it. I will start with a question from the chat that was one of my own also, from Dr. Svagi. How does the finding that pivastatin reduces airway smooth muscle constriction translate into epidemiologic findings? Do people who take statins have reduced
Very good question. In fact, did you review my grant? Anyway, review this grant. Anyway, this was, I mean, I guess it is a very logical and important question. So I have to give you a little bit of background here. So the issue becomes is lung versus first pass metabolism in the liver. You take statin as a pill, very little reaches your lung. Amir Zeki's lab did a whole bunch of studies, including monkey models, to confirm what I just said. Unless you deliver directly to the lung, you're not getting any benefits of a statin because it goes to your liver, first pass metabolism, nothing really reaches. So when we looked at those epidemiological studies, hard to interpret because all the statin users aren't, well, none of the statin users are currently inhaling it. And we did this very carefully. In Amir's lab, they're also comparing these, everything I said, they're comparing these with mice, monkey, and so on, just making the case that really the availability is, the mode of delivery is extremely important. So I will sort of leave it at that it's the previous data, they've this caution in their interpretation because none of that was delivered inhaled.
And one just related finding on the pravastatin note, I assume because mevalonate has nothing to do with it, other statins in the class have no effect. Is that right? Are they structurally similar enough to disrupt it somehow?
Very good question. So we did a careful, just for the purpose of keeping the talk to the point, I didn't explain to you that we screened about 12 different statins before we picked pitavastatin, right? And you know, statins are either lipophilic, they have different classes of statins. We discovered that at least the muscle, at least in terms of muscle relaxation, it is the best ones are lipophilic statins. Pitavastatin, simvastatin, atorvastatin, these were better than, for example, some of the others. I just can't remember immediately. Maybe pravastatin, and there is another one, lovastatin. But these three were kind of our top choices, and amongst them, pitavastatin stood out, most potent, and in our hands. And I will say these data I'm presenting to you today were our newest studies where we have discovered an acute statin-induced relaxation. We've previously published a paper with Amir Zeki's group where we took statins and treated cells for 12 hours, 8, 12, 24 hours, so much longer times. In that case, that is a mevalonate-dependent mechanism.
Oh,
so over long times, and that is the canonical mevalonate, Rho kinase, dependent inhibition of force. And we confirm that. That was sort of our starting point. But then we said, we're doing these measurements, and through that screen, we discovered this new acute effect, which is, and that's the part that I presented to you today.
Got it. Okay. Further follow-up on understanding that system. If I understand right, the pitavastatin data that you presented was on histamine-dependent contraction, right? Relaxation of that. And how important is the F-actin depolymerization and this mechanism in additional ways of bronchoconstricting? Have you guys, I think you did show in some other pictures, methacholine, but is this also leukotrienes and also, these other mechanisms?
That's a really good question. And I will say this, at least simplicity at this level of preclinical studies, we focused on one, we focused on methacholine, acetylcholine, I think we also used maybe a carbachol, but this is precisely why in Amir Zeki's lab, they're currently running an animal model where they're looking at pitavastatin given inhaled, comparing this in settings of inflammation or no inflammation to trying to infer what is operative and what is not. So that data is pending.
There's a group at the Karolinska, just thinking about the model that you've built and how applicable it is to everything. There's a group at the Karolinska that did maybe not precision cut lung slices, but dissected small airways, where they were able to use an ex vivo system to look at mannitol. And mannitol, as for us immunologists, is interesting because it will activate mast cells and immune cells that are in the tissue and then elicit bronchoconstriction in the secondary effect that, at least for those of us who are immunologists in the office, think is particularly important. Have you guys had a chance to look at whether do you retain enough immune cells to dissect those pathways in this system, or is precision lung cut slices too small to really look at that?
So I will say this, macrophages definitely present. Eosinophils, not so much. So other immune cell types, yes, are present. So there have been many studies, and I don't know exactly about mast cells, maybe not, but there have been studies where they have demonstrated presence of a subset of cells, not all. But I will tell you another group, what's more emerging now is people will often add exogenous eosinophils into these lung slices because the other cells are functioning. You can add neutrophils, along with your experiment. So those sorts of experiments, so if something is in deficit, you can introduce it into the model. And I will say, and I do know about the systems you're talking about, they're often, you can have either small airways, you can even have tracheal rings. There are many other models. But let me clarify to you why I think these lung slice models are advantageous. A given lung, we can obtain now upwards of 1,000 slices, right? So, imagine the strength for this. So thousands of slices from a given lung. Not every slice will have airways, but I would say about 40%, 50% will have airways. Those slices can then be cryopreserved. So by which I mean, so you've obtained these slices, you can, Mr. Frosty, liquid nitrogen, put them away. Months, years after, you can thaw them, it still maintains airway responses. And I've published some of these data too in mouse and human. So you can now bring them back to life, donor 1, donor 2, donor 3, condition 1, condition 2, and you can do your testing. And these tests can be done 6 well, 12 well, 24 well. You can do them in high throughput formats. So the convenience of, logistics, convenience, and that all these cells are interacting, these are quite advantageous in terms of using lung slices. But it is, it does not keep everything. But then there are now all these new studies where even in culture, it used to be one would have to finish an experiment in 3 days. Together with Yan Bai and her group, we've changed the media additives to keep it going for up to 3 weeks. Now there are studies months, and at least a month. And airway contraction is maintained in these slices. So not only can you keep them for, posterity, I guess, but you can also test them for much longer under conditions of interest.
Very cool. Very cool. So another question from the chat is from Jingbing. Very stimulating talk. Rama, do you have any clue what the long-term consequences are in the airway smooth muscle and possibly other structural cells? I'm going to throw in also epithelial cells there. If F-actin is targeted as a therapy for asthmatics, for example, are there changes in gene expression that could have damaging effects? That's her question, and mine is, could there be additional beneficial effects actually of disrupting that in epithelial cells and EMT that we see, right?
So, Xingmen, excellent questions. And this is, I will say, at least my take on why one has to be careful. First off, I have to say F-actin is prevalent in every cell type in our body. You don't universally, well, ideally, you don't universally want to reduce F-actin just indiscriminately, just everywhere. But on the other hand, I will also say that Rho kinase inhibitors, Fasudil, for example, is now being considered. You have compounds that can universally reduce F-actin, and that is safe in human and has potential benefits. So that is one class of compounds that universally hit. Statins are cell and context dependent. In the area of smooth muscle, acutely, they reduce F-actin. But in other cell types, I'm not sure these mechanisms are similar. I don't know if they do it to the same extent. So you have some compounds that can be more selective. And then you have, for example, encadherin, which is specific to area smooth muscle. And rather than directly reducing F-actin, through encadherin, you're specifically therefore perturbing F-actin in area smooth muscle. So this is kind of how I think about classes of compounds, either that is indiscriminate, cell type dependent, or really focused on area smooth muscle. So first answer to your question, Jingbin, is you can target where you can selectively target the area smooth muscle. But then your question about, and both of your questions about, what does that mean in terms of other cell types in its neighborhood? And I think that is the question, is we know from all this recent work that bronchoconstriction can by itself promote epithelial changes, can by itself promote area remodeling. So and I want you to appreciate that whenever we think about relaxation of muscle, beta agonists and so on, these are short-lived, acute. It relaxes quickly, which we needed to do so, but then, that effect is gone. And you have to keep kind of perturbing. But the goal here is if you can perturb the F-actin, and the contraction more permanently, your pre-existing tone is reduced, especially in severe asthma. And that is certainly going to have effects on epithelial mechanobiology, mast cells, and eosinophils and recruitments. For example, and I'll tell you another thing, the study with the protease allergen. Whenever you have local gap formation, which again is an epithelial biology, but the mechanobiology of that process in turn attracts eosinophils to come locally and populate. So changing the biomechanics of the microenvironment is hugely important, is kind of what I will say.
In follow-up to some of your comments about specificity, your thoughts about the specificity for some of these mechanisms, is that because cofilin is more uniquely expressed or higher level in smooth muscle, or what gives you that sense?
I don't want you to think in this manner. Cofilin is also ubiquitous. Okay. It is global, it's present, I think, in any cell where there is a focal adhesion. And this is why I sort of said working hypothesis. With statins, I am fairly certain it's not just going to be cofilin. Cofilin is one amongst many, but ideally, there are other specific compounds, rather specific proteins in the muscle that the statin can selectively target in smooth muscle as compared to other cell types. So I don't want you to go away thinking, well, here is the mechanism. It's through. Cofilin is clearly an important mechanism here that we've discovered. But the fact that statins work differently in different cell types may have to do with things beyond cofilin and even contraction. It may have to do with, statins can also affect cholesterol in the membranes. It can affect, and all these, hypotheses we are still continuing to test. Sure. And I did want to say one other thing. I'm sorry, I should have mentioned this earlier. I want also for us to remember that we all appreciate that bronchial thermoplasty works. Taking that area smooth muscle out helps that severe asthmatic, in terms of mechanics of their airways. So in the way I think about F-actin dissociation is sort of my way of killing the area smooth muscle selectively. If you can not kill it, well, impair it. That's kind of how I think about it.
One more question about the specificity issues. You did mention that encadherin is, highly expressed, obviously, on the smooth muscle, but it is also expressed on epithelial cells after they've undergone EMT, right? That's one of the markers. So I wonder, have you thought about this mechanism in the mesenchymal cells that put down matrix and stuff in other settings?
You are absolutely right. It's also expressed in fibroblast. That's why I said largely. I used that word kind of loose. Fibroblasts have them. So I believe it may also reduce area remodeling in severe asthma. And this is, in fact, a grant together with Jingbin Yan and some others, I think in the call, Jenna Park maybe. We've been pursuing this question, is what can do in addition to this particular effect? And I will also say that my Encadherin as a pathway has been actively pursued in the settings of fibrosis and cancer. The compound that's developed has been developed as an anti-cancer compound. And I'm repurposing it, for our setting. That's kind of been, I think, a very important approach. Is you have these compounds that have gone through phase 1 trials, safe to use in humans. And it turns out in that human study, what particularly attracted me is there is no maximum tolerated dose. You can keep increasing. Humans, there's no trouble. Mouse study, same thing. Anyway.
Great. Okay, so we'll do this one last question and then we'll end on time. It's from Rod Rahimi at MGH. He says, given that mucus plugs can also significantly contribute to airflow obstruction in severe asthma, can you comment on the potential benefits and limitations of topically targeting the smooth muscle alone?
That is, it's fair, it's important. I will say that, at least remember, in our lung slice-based studies and in our cell culture models, we infuse the airways with agarose. The effect of mucus sort of is not something that we can actively study, yet we see benefit, right? And then we see a circumstance such as in our mouse models with encadherin antagonism. Those mice treated in the settings of, AHR, plus minus encadherin, mucus hypersecretion levels, all that stayed the same. And yet we saw benefit to AHR. Yeah. So I will make the point that I completely agree with you. And I have a feeling, and this comes back, Nora and Jinbin, to your question about perturbing actin. I think if you can kind of loosen up that airway, fluidize the muscle, you likely can also enhance maybe mucus clearance or some sort of, you can have effects on other pathomechanisms in the airway.
So it's on a related question, just to follow up that one piece, if you specifically target this mechanism, you did mention that in one of the mouse studies that the inflammatory cells, that this worked despite the fact that there was similar inflammation. But I wonder whether you've had a chance to look at whether the immune cells that were coming into tissue were equally as activated, because you might wonder about whether the mechanosensors that are present on immune cells might be more quiescent and not contribute as much to active inflammation in that setting.
That is an excellent question. And Nora, I think you might, this is precisely why you put in this grant. This was the question we've asked, one of our many questions. That experiment I presented to you is still one circumstance where we did 24 hours of stimulation and looked at it the day after. This is not a chronic asthma model where we waited long enough to see sustained and sort of more changes in terms of exactly mechanobiology of the airway in itself. We've just done one quick perturbation, 24 hours, and looked for resistance changes. So I think we will see a lot of these other factors too. And that's amongst the things we want to study.
Very cool. All right, we will end there and on time. Thank you so much. And thank you for giving us 20 minutes to pepper you with questions. Really appreciate it.
My pleasure. I enjoy that as well. My pleasure. Thank you.
And with that, we'll conclude. Thank you, folks.
Mm-hmm.